I am here with one of my favorite people in the world, my friend, my colleague. She has been on the show before. You guys all love her. You love her creams. I love her creams. Karen Martell, hormone expert. I asked her to come back on today because lately I have been seeing in my practice a huge uptick in breakthrough bleeding and breast pain. And I thought, who better to unpack this and break it down and give us real answers on what the hell we can do about this than Karen? So thank you for jumping on, Karen. I appreciate you.
Anytime that I can sit and chat with you face to face, I will. Anytime I can come on weekly if you want, Amy.
I know, seriously, we just
Yeah,
have so much fun. I think half the time we do this for ourselves just to be
I
able
think we
to
do too.
catch up and
Yeah,
learn from each other. But no, this is
absolutely.
huge. I mean, you were the first person I reached out to when I started seeing, and really it's been like a 3 to 4 week block of patients. And then in the Facebook group, I'm seeing people post about this. And I'm like, wait a minute. What is the, and we'll start with the breakthrough bleeding. What is
Yeah.
this uptick in breakthrough bleeding? And it's not just menopausal women that haven't had a cycle for 2 years and now are having cycles or spotting. It's across the board. It's all age ranges. It's even women that have a regular cycle, but they're getting a second cycle, or they're going every 3 weeks now, or they're spotting in between their cycles. And I cannot figure it out. So, wherever you want to start, I'm game to start. But that's the issue at hand that I want to break down.
So I can't say that I would know, 100% why it's happening just more so maybe right now. The only thing that I can think of that could maybe be creating this uptick is if people are getting vaccinated still. And I know that that's a very like hot topic, very taboo to talk about. People don't want to hear it. But that's just common knowledge, I think now. I
At
hope
this
it is
point,
now.
yeah,
At this
yeah.
point, that vaccinations, the COVID vaccination in particular, did have an effect on women's cycles. And so we were seeing women having their period come back that were in menopause, or women that were cycling suddenly go missing with their cycle and just messing with their cycle. And that's not just the vaccination, but it's also if you get COVID, that it can affect the ovaries. Apparently, and I don't know if this is true, so do not quote me on it, people. My naturopath actually told me this. She said it's because the spike protein settles in the ovaries. It's one of the
Yep.
spots that it'll settle in. So, if that's the case and it's causing inflammation to the ovaries, we could maybe say, okay, this is why this is happening. John Hopkins Center was actually given $1 million to look into why COVID and the COVID vaccine was affecting the menstrual cycle. And so this is not something that's conspiracy. This is something that was actually happening and being reported by thousands, hundreds of thousands of women during that time. Now I know we're out of that, but we're still seeing people getting COVID. And this is winter right now at the time of this recording. So maybe people are getting viral infections and it's affecting their ovarian function. The only other thing I could think of is that maybe women are changing their dosing around, and there's a lot of talk right now on social media about not using the smallest dose possible with HRT. And so practitioners and patients themselves are like, I want more. I want to be optimized on my HRT. And whenever we raise the dosage up, especially of estrogen, but also it can happen with progesterone, we'll talk about that, then it can affect the way the cycle is acting. And that can be heavier bleeding, breakthrough bleeding, things like this. And so if somebody's not being treated properly or they're DIYing their HRT, which I'm all for, but when things like this start happening, then you should probably be working with a practitioner who knows how to address the breakthrough bleeding. So in today's discussion, I'll go through the things that could be causing the breakthrough bleeding just in general. So not saying like, not just right now because we're seeing this uptick, but just general, because it is something that's quite common. I do have to say that we see it often in our group where women start HRT and a couple months into it, they're breakthrough bleeding. Sometimes right away, their breakthrough bleeding. I
Hmm.
had a woman yesterday that was like that. She's like, as soon as I started estrogen, my period came back. And she said, I haven't had a period for 2 years.
Yeah.
And
Yeah.
this was within days. And I'm like, oh, that's so strange because usually it takes a little bit longer. So
Right.
I don't know. Maybe it's whatever's causing this other uptick in it that she's got. I
Yeah.
don't know.
Well, I
But
agree with you. That was a known thing a few years ago when the vaccines rolled out and COVID had
yeah,
a huge uptick in just the cases of COVID. That, like you said, this is known. This is known. We know that 70-year-olds
it's not
were starting to
conspiracy.
get their cycles. But you're right. And then we had the spike protein and the shedding. So even if maybe women are around other people who got boosted and now they're
Yes.
actually shedding that vaccine, or you're around people that had COVID and you didn't, they can shed the virus. So it could be that. And I'm with you. My stepdaughter was one of the millions of people that were forced to get it because she went to University of Michigan and her cycle just flat out stopped. She was regular, regular, regular. She lost her cycle for a full year. So it's
Yeah.
definitely affecting it. But you're right. Outside of that, I want to get into why do we see it just in general? If we're 10 years
Hmm.
down the road and we're seeing breakthrough bleeding, just the why is what I'm looking for.
Yes. Yeah. And I think the first thing that I want to say is it's normal. Women panic.
Yeah.
They start their HRT, and because of all of the misinformation about estrogen that still is going around heavily, they immediately think that they've got cancer or this is causing harm to their body because they start breakthrough bleeding or start bleeding after being in menopause for a certain amount of time. They
Hmm.
start HRT, estrogen replacement therapy, and they start bleeding, breakthrough bleeding, and they panic and they're like, "What? Like, and I don't want this to happen. And what? Why is this going on?" And even though we give everybody a handout that says this is very common to happen, they still lose it and they still are reaching out going, why is this happening? I'm freaking out. Number one, estrogen is proliferative. It grows the uterine lining. So it is doing its job, women. Okay. It's doing its job. And so you have to know that yes, sometimes there are things going on like fibroids, polyps, overgrown uterine lining, maybe that you didn't know was overgrown. And then you start using HRT, and that causes some breakthrough bleeding because the uterine lining was already too thick. And so then that is like the tipping point, and now it grows it even more. And then now we're having breakthrough bleeding or heavy bleeding happening. But
Hmm.
in most cases, it is just a matter of dosage, application form, and the body adjusting. So if you've been without estrogen for a long time, the receptors, interestingly, I was taught that the receptors downregulate when there's no estrogen, but actually they upregulate, which makes more sense when you think about it because the body's without estrogen. So now let's say you're in late perimenopause or you're in menopause without estrogen or a lot of estrogen. Your receptors are going to, it's like their mouths get opened even farther and there becomes more of them. So you can think of all these receptors like looking for estrogen. It's so desperately that they're going to be wide open because they want to catch anything they can that's estrogen and bring it in.
Hmm.
And so these receptors all are just waiting eagerly, super sensitive. You start using estrogen and it's like they just, and you can think of it as them, they're just sucking up all this estrogen that you're now putting in your body. So you go into an estrogen dominant state for a period of time, and that causes breast tenderness and it can cause breakthrough bleeding or heavy bleeding. The trick is go lower and go slower. That's the thing. Like, even if you have like no estrogen on your blood labs, and so then the doctor's like, wow, you could use, a milligram to 2 milligrams a day. And they start you off on that. That could just send your whole body into a tailspin of estrogen dominance. And you start bleeding super high. So even though you needed it and your labs show that you needed that dose, It doesn't matter. You're too sensitive for it. And so that's your sign that's too much too fast. And you can bring that dose down. And sometimes you have to start very small, like 0.25 milligrams, even half that to some women. The longer you've been in menopause, the smaller the dose you should start with.
Okay. Yep.
Yep.
So even if
Oh,
it's paired with progesterone,
yep.
which it should be, you should never be
Yes.
taking estrogen alone or estradiol alone. So even if it's paired with progesterone, it could still come back to not necessarily the estradiol to progesterone ratio, but just the estradiol level itself.
Exactly.
Okay.
Exactly. And progesterone oftentimes isn't dosed high enough, and sometimes it's dosed too high. And it has a lot to do with this breakthrough bleeding, way more than people think. And so, one, it can be that your body's super sensitive to the estrogen. You've been into menopause, you've had no estrogen for a while, so these receptors are too sensitive. You have to back it back down. You may not have to change that progesterone dose, but you need to back down on the estrogen, go lower and slower. The longer you've been out, you're going to take even longer to increase your dose and titrate up. So you could be at that half dose of 0.125 for 4 weeks before you can even go up, depending on how long you've been out for. Like if you're 70 and you've been in menopause for 20 years, that's probably how slow you might have to go
Okay.
without getting those symptoms. Then comes the progesterone. So let's say you've lowered your dose, but you're still having troubles with it. Now we want to look at progesterone. Is there enough? Are you absorbing your progesterone? A lot of women, especially for you, Amie, have digestive problems. Thyroid, we know hypothyroidism is one of the biggest things that it's going to affect is your bowels.
Mm-hmm.
If you don't have a great digestive system, which I don't think many people do these days,
No.
right? Most people
Right.
have some
Everybody has
degree
leaky
of
gut.
leaky gut.
Yeah. Yeah.
Guaranteed, if you have Hashimoto's
Right.
or any autoimmune condition, they say guaranteed you're going to have a leaky gut. So you've already got this compromised gut system, and now you're taking progesterone orally. Number one, progesterone naturally shouldn't be taken orally. And I think we're going to see a shift in how we're going to take progesterone HRT in the next couple of years. I know that one of the leading experts in female hormone replacement therapy, Dr. Felice Gersh, is publicly now coming out to say she does not think that we should be taking oral progesterone.
Wait, why? That helps
Yeah,
me sleep. No, the cream does
I
not help me sleep. The
know.
oral does.
Yeah, and I think that there's enough women on oral progesterone, Amie. I would say 80% are given oral progesterone now, that we would know if it was causing a lot of adverse side effects.
Right.
Right. So we always have to keep that in mind. It's like how many hundreds of thousands of women are taking oral progesterone, and some of them very high doses, and some of them have been on it for 10 plus years. And if we're not seeing this increase in breast cancer or heart issues, and that's what she's found a little bit of evidence to show that it could negatively affect heart function. And then there's a little tiny bit of evidence from this one guy that's showing that too much oral progesterone could cause inflammation of the breast tissue and increase your risk of breast cancer. But
Okay.
this is one research paper, and so they really don't. They're like, do we need to really believe this because we're not seeing an uptick in breast cancer? So controversial, right?
Right.
But I say it's probably fine. And I think what we need to be aware of is dosage. So in our practice, we don't go higher than 200 for oral
Mm-hmm.
because of that little bit of evidence that's showing that breast inflammation can happen and this hard stuff. Then it's like, let's just make sure that we're keeping in safe dosing forms. And so to me, 200 is what your body would naturally produce of progesterone, because you're only going to absorb about 20% of it is going to be actual progesterone from oral,
Right.
because it has to go through the first hepatic pass of your liver and then go down through your digestive system. So you're not left with a lot. So you're getting about 40 milligrams from 200 milligrams of oral progesterone, which is about right. when we use transdermal, we use anywhere between 50 to 80, depending on the thickness of the skin and if they're absorbing it well enough. But
Mhm.
usually 50 milligrams is sufficient for most women to use transdermal. So that gives you an idea of what it should be dosed as, right?
Mhm.
So naturally, we don't produce progesterone and then it goes through the first hepatic path to the liver and then through our digestive system. That's not naturally how we do it. So some people, because they have compromised digestive systems, and maybe this is not the most natural way for us to be given progesterone, they will have troubles absorbing it. And so they might not be on enough progesterone to counterbalance the growth of the uterus that from their estrogen. And so that will cause the breakthrough bleeding, the sore, tender breasts, the heavy periods. And then you have to look at, okay, if I'm already on 200, or if you're on 100, definitely go up to 200 and see how that feels and see if that stops the bleeding.
Mhm.
But if it doesn't, then you got to go, okay, maybe I'm not digesting it great. And maybe I need to try a different form of progesterone. So that's where we would go, okay, let's try doing twice a day transdermal cream.
Mhm.
If that doesn't stop it, you can then go to suppository. And that's one of the best ways to just get it right into that uterus. And there's no messing around with are you absorbing? Are you digesting? It's just right there in the uterus. And then it can counterbalance that growth. And we see really great success using vaginal progesterone suppositories. And we also see it working really, really well if there are fibroids or any sort of growth or overgrowth of the uterine lining. One of the best ways that we see helping that is a higher dose progesterone suppository. And you can even use it daily for a certain amount, like 3 months, just to really shrink those fibroids. And we've seen that work. We've seen it work. Some people, we've seen it not work, and they still had to go get surgery because the fibroids were too big. But that is a really great way to stop that uterine bleeding is to use vaginal suppositories. And so everybody keep that in mind. And that's something you can try out. Then we're going to the opposite end of the spectrum, which is too much progesterone in comparison to your estrogen can cause an unstable uterine lining and cause you to have breakthrough bleeding. And a lot of people don't know that because doctors are like, here's your progesterone, higher, higher, higher doses. Oh, you're having breakthrough bleeding? We're going to increase to 400 oral progesterone, 500 oral progesterone. And it just keeps going up.
Mhm.
And they're being told to take it every single day, which is not the natural way for your body to take on progesterone. It should always be cycled. And so now you have progesterone going in there every single day, counterbalancing this estrogen. You don't have enough estrogen. And so it's just sloughing off that uterine lining nonstop. And then you just have this nonstop breakthrough bleeding.
Now,
So
wait, let me
sometimes
pause you right there
yeah,
real
go ahead.
quick, because I'm going to forget to ask you this. You're talking about the sloughing off. What about the woman who she has a normal period? She started on progesterone because she's in her, like, let's say late 30s, early 40s. Doesn't need estradiol yet, has a normal cycle, starts on progesterone, takes that break during days 1 through 14, but then she gets confused because now, wait, she's having a cycle on day 5. Should she stop the progesterone then and then wait it out and then restart it? Oh, but wait, now she's having basically 2 cycles in a month with some breakthrough bleeding as well. When do you stop the progesterone when you're so erratic like that?
That takes some biohacking, I find.
Okay.
Honestly, because this happened to me several times over my perimenopausal years. It still happens where it'll just suddenly change and I'm like, I'm getting a period every 2 weeks and then I won't get a period for 3 months and then and this happens to a lot of women, especially in perimenopause because
Yeah.
things start to get so erratic and we don't know when sometimes you ovulate, sometimes you don't. So sometimes you have extra progesterone, sometimes you don't. I say that if you're taking your progesterone and you get your period early, I would recommend stopping it, waiting 2 weeks and starting it again. Normal, like that's what would be normal, right?
Hmm.
If the period comes a week later, early again, Then that following month, you would start your progesterone on day 10.
Okay.
And if it continues that you have a period for every 3 weeks, which can be very common in perimenopause, then you would use it from days 10 to 21.
Okay. That makes sense.
If the period starts to regulate itself again, which it could, then you would go back to days 14 to 28. You always do want to try and get 2 weeks in there. And sometimes it takes a little bit to figure out, is this going to be normal? Is this my new normal? And if it is, then you have to wind it back. Some women have to even start on day 7. And it's like they have that 7 days of period, then they'll start their progesterone. And I'll tell them to increase it on day 14. So they'll have maybe 100 milligrams oral for the first 7 days, and then they'll go up to 200 and see if that increase can help the period not to come. And okay, this is confusing. I understand, everybody. This is very like we're being very detailed with
We are. We are. We're getting
right.
detailed, but
We're getting
pressing
detailed, and
question.
this is why it's always important to work with somebody, because everybody's different and this can get very confusing as to how to biohack this yourself. But basically, if let's say you started on day 10 and it was day 21 and you've been taking your progesterone and your period doesn't show up, I would advise to continue taking the progesterone to day 28 and then stop, because you're trying to help your body to regulate itself. And
Hmm.
so if you can get back to that 2 on, 2 off, you want to get there. That's the goal, is to keep it there. And sometimes that's okay. Now we need to increase estrogen because we need estrogen in there for a normal cycle. And we want to get to a place where we have 28-day cycles, even in menopause, because menopausal women on HRT, in order to get that estrogen high enough, and we're cycling progesterone, you're going to have a light period once a month for a couple days. And some women are a hard no on that. And if that's the case, then you could take your progesterone every day and you won't bleed. But that withdrawal bleed from the progesterone is something that I feel we should be working towards and
Hmm.
trying to get to, no matter what, whether you're perimenopause or menopause. And so that's going to take adjusting both of your hormone, progesterone and estrogen, till you can get there. And I think a lot of people are too lazy to do it like that. Like I am, for sure. That's why I have, like, sometimes I'll go missing my cycle for 2 months, and then I'll be like, oh, no, I'm getting my period every 2 weeks, and I'll increase my progesterone and see if that helps. But I'm not like super exact about it because I just don't even care. I'm like, well, this is perimenopause.
True. Right.
As long as I'm using my progesterone enough and I'm using enough estrogen, then for me, a lot of the time that can be okay. But I'll try and biohack a little bit, but I'm not super regiment about it. I should have a calendar and, gear myself up to do that, but I don't.
That's all right. Yeah, we are our own worst patient, that's for sure. But as long as we
Yeah,
can
yeah.
tell other people what to do, that's all that matters.
Right? Yeah. I mean, you really measure yours out, do you not, Amy? Like you're really trying to cycle yours.
I do because I'm on the Wiley protocol
Yeah.
and cycling that, but I've been doing it for so long that I'll get lazy too, and I'll be like, "How many clicks was that again from last week?" Oh yeah, and I
Exactly.
don't even look at the calendar, so
Yeah.
I'm just as bad. I am.
Yeah, same. And I'll be like, oh, it's probably around day 12. And I like to spike my estrogen once a month. So I'll be like, today I'm going to just use extra estrogen,
Yeah,
and so,
yeah. Don't
but
do as we do, just do as
yeah,
we
right. Yeah,
say.
exactly. Exactly. Yeah. But we also know that there's nothing, we're not afraid of the bleed, which
Right.
we're talking to women that are very afraid of this. And when this starts happening, they do freak out a little bit.
Hmm.
And so there's some tips as to, how to kind of biohack that yourself. But know that if adding in progesterone doesn't solve it, or changing how you're taking it. So let's say you go put it in the vagina and it's still you're having this break. Then I would flip it and see if it's that you need more estrogen and maybe a different, like less progesterone, not a whole bunch less, but a little bit less. And maybe you need to cycle it better and do 2 on, 2 off or something like that. So know that it can be too much progesterone, but usually it's too much estrogen and not enough progesterone. So that's the first thing that you want to try is that route. Next to that, you're going to want to be patient because it can take about 3 months for the HRT to settle in. And a lot of people, they get impatient and they immediately think and freak out and they're like, oh, I'm bloated, my breasts are tender, I'm having breakthrough bleeding. It's like, actually, those are all really normal things to happen when you start HRT. And it's for all the reasons I was talking about. And then some women don't process their hormones very well. So if that's the case, then you want to look at different supplementation. You want to maybe do a urine metabolite test, see which pathways you're breaking down, see if you need support on any of those pathways. Doing genetic testing can be great. I just did a great episode about this, all about like different SNPs that you can have that need to be supported when it comes to estrogen and testosterone or androgens in general. And so seeing what your body needs to support those genes I think is such an important piece of the puzzle because then it makes so much sense too. It's like, oh, I don't oxidize very well. I need extra antioxidants. Oh, I don't do well with the 4-hydroxylation pathway, which is like the CYP. I can't remember what they all are, but I'm not a genetics person, but I've done genetic testing twice, and it's so great to see where does your body need that support. And then you're not guessing and buying all million different supplements. You're going to know, okay, my body needs this, this, and this. This is what I'm going to take moving forward.
Mm-hmm.
And then that'll help support those pathways because if you're not metabolizing, so you start taking estrogen, let's say you drink regularly, which is of course very common. Your gut's not great. Maybe you're overweight. You're not great with the food. You start taking that estrogen, you could go very estrogen dominant very quickly. And just because you're not processing, even though you're not even taking hardly any estrogen, you're not properly metabolizing it, which then it gets backed up into the system and recirculated. Or if you have a lot of xenoestrogens in your body, you're drinking a lot of alcohol, which is in and of itself is estrogenic, and it's not a great estrogen. It promotes estrone, which is an inflammatory estrogen. So you start taking estrogen, you're piling this on top of a body that can't handle that. You're going to have estrogen dominance and you're going to have breakthrough bleeding. And so cleaning up your gut, slow down or stop the alcohol. Our bodies cannot take it like they used to. When menopausal women, unfortunately, because people hate hearing this, we should not be drinking. And if we do drink, it should be on the rare occasion.
Yep.
Honest to God, ladies, like this is one of the biggest issues that I'm seeing. And maybe, Amie, now that I'm saying this, that could have something to do with the uptick because wintertime people drink because they get depressed.
Yeah, they're in the house. Yeah, exactly.
Right? We just came out of Christmas.
Mm-hmm.
You never know, right? But people don't, like I said, people don't like to hear that, but you have to know that you got to have a cleaned up system in order to handle that HRT. Some women can slap it on and they do great and they're on their merry way, but majority of women, they need tweaking, they need adjusting, they need to have support on these different pathways so that their body can metabolize their estrogen HRT. And so we do want a cleaned up system.
Yeah.
So that's really, really important. And that could be taking things like, just a methylated B complex. So we're methylating properly in phase 2. See if you have problems with methylation. Do you need maybe some N-acetylcysteine? That's probably one of the best supplements that I recommend for women that aren't processing their estrogen right away when they're taking it. So if you're getting weight gain, breast tenderness, N-acetylcysteine, it can work wonders for that. And then know that it can take 1 to 3 months for those side effects to go away. And those side effects are very normal. So you might just have to wait it out and let your body do its adjusting. And almost 99% of the time it goes away.
So at what point of time would you tell a woman you need to go get a vaginal ultrasound? Because I know that that's pretty common, almost like a cover your ass move as well for many prescribers, that when they hear that a menopausal woman has breakthrough bleeding all of a sudden, let's go get a vaginal ultrasound.
I think it should be done quite quickly. especially
Okay.
if it doesn't go away with adjusting the progesterone. I would go, I would just go for peace of mind for the patient. Like
Hmm.
peace of mind, just go because you're freaking out. Go and get your vaginal ultrasound so you know that there's nothing amiss for peace of mind, if anything. But if it's continue, if the person's like, nope, not going to do that, and they just want to try and biohack their way out of it, okay, go ahead, try to adjust. Let's do all these things that Karen's talking about. If it's still happening, then please go get a vaginal ultrasound because that's the sort of thing that you want to rule in or rule out. If there's fibroids, it's a whole different story, right? If there's ovarian cysts, it can be a different story. If there's an overgrown uterine lining, that could be you're going to have an increased risk of uterine cancer. This
Hmm.
is not something we want to mess around with. So, on one hand, very normal for all of this to be happening, but if it's like out of control and continuing to happen no matter what you're doing, then go and get an ultrasound done and let's see if there's something in there. And a lot of the time, when we see that none of those tricks are working, it's usually fibroids.
Mm. Okay.
Yep. And they're
Okay.
usually we're in there, probably smaller, not causing problems. You start using estrogen, which is growth promoting. And some of them actually have progesterone receptors and can cause the progesterone can be a factor to grow them.
Okay.
Most of the time it's the estrogen, but progesterone can happen. Um, yeah, at that point, suppositories, iodine,
Mm. Yep.
huge for fibroids, breast cysts, right? So if you're getting breast tenderness, we want to look at, and that's maybe we can start talking about that too, is
Hmm.
iodine deficiency, right? So you've got a thyroid problem, you're getting breast tenderness or breast lumps, maybe you've got fibroids, iodine, iodine, iodine.
Yes. Yes, yes, yes. All day
Get
long.
your own iodine, Amy. We're
Oh,
waiting.
no, it's in process. Like it's coming soon. Iodine Fixxr is coming soon. Yes. Yay.
Can't wait. I'm having it. I'm going to have sell it in my shop too, because so many people are deficient in it. You know this, and
Yes.
so that's growth, and and it helps us to process our estrogen. So iodine, calcium D-glucarate can be really good. Breast tenderness. Now, this is a bit different of a ball game because there's the cycling woman that gets it pre-period, but then there's the woman that starts HRT who's getting really crazy breast tenderness, breast lumps, itchy, sensitive nipples. This is all because of starting that estrogen HRT usually. Once in a blue moon, it's from the progesterone, but it's usually estrogen. And there's a few things that can cause this. Cycling women and sometimes HRT women,
Hmm.
caffeine intake and chocolate are some of the
Oh,
worst culprits
the
for
hell? You
premenstrual
can't take
breast
those.
pain. Right? Isn't that the most meanest
That's
thing in the
horrible
whole
news,
world?
Aaron. That's horrible.
I
Right.
know. When I discovered that chocolate was the worst thing ever for breast pain for me, I was devastated.
Yeah.
And I can't eat it. Like if I, a little bits here and there, but if I have consistently eat like Christmas time and there's all this chocolate, no, my breasts will be, I can't even touch them for 2 weeks.
Ah, yeah. That's
It's
not fun.
sad. So yeah,
Not
so
fun.
look at your caffeine intake, unfortunately, if you're having a lot of breast pain. Cycling women, look at your progesterone, or you probably could use progesterone on that second half of your cycle, and that will get rid of the breast pain. I love progesterone cream for breast pain and breast cysts. So if you're getting wherever you are in your cycle or menopausal, progesterone cream rubbed directly on the breast tissue, whether you have cysts or it's just swollen, tender, rub that cream right on the breast tissue and it works faster than anything to get rid of breast cysts and lumps. Like
Okay, well,
it's
wait, pause right
magical.
there because we can use your cream for that. So you don't necessarily have to get a prescription. Like, let's say you're
No.
on progesterone, you're on oral progesterone, you're on HRT, you're feeling good, you just got this breast pain. Rather than going back to your prescriber and be like, hey, can you compound me a progesterone cream so I can throw it on my breasts? And then they're concerned about, well, yeah, but now you're on the oral and the dosing and all that. Why they could very easily just get your progesterone cream and put a little bit on, just do it over the counter,
Absolutely.
right? Yeah.
It's what I do. Yeah.
Yeah.
Yeah. Yeah. I went through a phase where I was getting breast cysts and I would just rub it right on the breast cyst. It would go away in 2 weeks. It was crazy, but it
You
works
just need a
really, really
little
well.
bit. It's not going to throw off
Yeah,
your
yeah.
levels like crazy, you know? Yeah.
No, it doesn't. Like if you used like a quarter pump even is probably plenty to get on the breast tissue. And adding that little extra to your oral progesterone's typically fine. Like women won't notice any sort of adverse side effects because it's topical progesterone. And if you were adding a bunch of oral, then you might get too sleepy and too moody. But with adding the topical, no, it just doesn't, it's not, doesn't do have the same side effects as the oral does. And so that's a great, I think between that and the iodine, it's two of the best things for breast cysts and breast pain. If you're cycling, you could also look at prolactin issues. Things like primrose oil can be really good for breast pain. That's been shown to help with the lowering of the prolactin levels in the body, which can cause that breast inflammation. Women starting HRT, you want to look at, once again, you want to just wait it out. If it doesn't go away after a month, okay, you can do things, about it because it's showing that maybe you're not processing your estrogen very well. And then same things, N-acetylcysteine, calcium D-glucarate are all great things, methylating properly. And then you can look at things like your diet. So are you having too much caffeine? Look at all the products you're taking. Is there extra caffeine in anything? Um, Chocolate, so sad.
Once again,
Uh,
chocolate coming in.
yeah, yeah. And then you also can look at histamine, which is, that sounds like an odd thing, but if too much estrogen has a correlation with rising histamine levels. And so if you have mast cell activation or histamine issues, that can cause some breast inflammation when you're first starting the HRT. Water retention, electrolyte imbalances. So you want to make sure that you're taking electrolytes. I always think that electrolytes should be taken daily for women.
Yeah.
Thyroid function, adrenal function, processing of the hormones. We need these essential minerals to help your body with all of these things. Amie and I both take beam minerals, which is a great staple for just everyday electrolytes.
Mhm.
But there's lots of different things on the market. But on top of that, I do even more. Like every time I drink water, I'm putting some form of electrolyte into that water, whether it's sea salt or whether it's something, all of those things is going to help. You want that magnesium, you want that potassium. It's and the diuretic, both of those. And so it's going to help you shed any sort of excess water weight that you might be packing on because of the HRT. So
Sure.
it's just going to help your body to process the HRT. And I see it working really, really well, all of those things.
Yeah. Okay. Now, do we have to worry about the breast pain? I know a lot of women just freak out when they get that little
Mm,
twinge. I mean, myself included. I have had breast pain, even though I know better that it's probably nothing and it's just coming from the HRT and a little bit of an imbalance. It still really messes with your head. You're like, oh man, do I have a cancer here? So, at what
yeah.
point do we tell women don't freak out, don't worry about it, don't over worry about it, and hey, if it's going on for a while, go get it checked. Like, where's the line there?
Have you ever had a breast cyst?
I found a lump years ago that had to be biopsied, but I didn't
Hmm.
even I didn't even notice it. It wasn't associated with pain of any kind.
How did you find it?
Actually, my husband, he's like,
Okay.
I'm I'm
Which
feeling
is, that's
right
what,
there.
yes. Yeah. 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 Great.
TMI people,
Great.
but it's true. Y'all know you do it too. So yeah,
Absolutely. Yeah. I was just watching a movie the other night where a guy discovered his wife's breast cancer by feeling her breast and was
yeah.
like, what's this? You should always, as women, be feeling your breast tissue because you want to do self examinations. It's one of the best ways to help catch breast cancer.
Hmm.
And it's one of the safest ways because mammograms, as you know, they cause radiation to the breast tissue. So
Right.
doing self-examinations is really, really important, especially as for menopausal women, because this is when the breast cancer rates go up, is in menopause. Get to know what your breasts feel like because when you have lumpy breasts, premenstrual, or you just have lumpy breasts, they're very obvious. It's like you can feel the glands. It's like, oh yeah, there's those lumps and bumps. When there's a cyst, number one, if it's a benign cyst, it's typically very obvious. It's like a little round sac in the breast tissue that's really smooth on the edges, and you can move it around. Rather, breast cancer typically, not always, but typically, women say it was so obvious when they found it. They said
Okay.
it was hard. It had really bumpy edges. They say it almost feels like a rock was in their breast. It was not smooth on the edges. It's like it's embedded in there and it's very rigid and not smooth. And it's
Hmm.
quite obvious. I mean, you obviously, if there's a cyst, you probably still want to go and get that checked, of course, ultrasound, whatever. But you can very easily distinguish between what is just lumpy sore breasts and ooh, this is not something I'm feeling on the other side. This is not just a little tiny cyst. This is something else. So get to know your breast tissue. And then if there's ever doubt or fear, then of course, go have those fears squashed by going to the doctor, getting an ultrasound done on your breast tissue, make sure it's nothing abnormal. There's many different options. There's thermography now. There's the one that Dr. Jen Simmons talks about. I can't remember what it's called, but you put your breasts in water and it's better than a mammogram. So there's safer ways coming out to check for breast cancer. And it's something that you do want to be checking. But if you've just started HRT and your breasts are swollen and sore and lumpy, more than likely it's simply that you've started the estrogen because that is such a common side effect. So it's always like, okay, let's just wait it out and let's see if it goes away. If it doesn't go away and it continues and stopping the estrogen doesn't stop it, well, then obviously you'd go and get that checked,
Yeah. Yeah. Totally.
right?
I love that.
Yeah. So I think it's really important for everyone just to know it's normal
Yeah.
that to happen when you start estrogen, HRT.
Yeah.
And that okay, let's just wait a couple weeks here and let's see if it gets better because normally within 30 days it gets better
Well,
and
and the
goes
funny
away.
thing is, you said it's normal. I summarize this for my patients. We can summarize it on here too, whether it's breakthrough bleeding or breast pain. I have breakthrough bleeding. I have spotting. I have breast pain. Okay, so let's break this down. It could be too much estrogen, not enough estrogen, too much progesterone, not enough progesterone. Yes, I mean, it's just like all of the above. You don't really know, which comes back to your comment on working with someone who does know what they're doing. You don't really know the why. Sometimes it is trial and error.
Yeah.
There's no manual for this. Like none
Yeah.
of us in the hormone space have a manual that goes, okay, so if a 50-year-old woman has breakthrough bleeding, you do exactly this. No, there's nothing.
No.
Everybody is so unique.
Yes. And in hormone replacement therapy needs to be individualized. And I think that women assume that it's just this blanket dosage and it's just like here's your patch, here's your oral progesterone, see you and you're going to be fine, and that's not the case. And you want to make sure too that your levels get to an optimal place. It's not about the lowest dose possible to get rid of those hot flashes.
Right.
No, we want optimization so that our brain is healthy, that our bones are healthy, our
Mhm.
heart is healthy, and that comes with a certain amount of estrogen and progesterone and testosterone in the body. And so we want to be optimized. And that's going to take some time. It's going to take some trial and error because you can't just go from zero to, oh, I've got a level of 5 for estradiol and I'm going to try and get you to 100 so that you get the therapeutic benefits of estrogen. Well, that jump, oh my gosh, there's so much that can go on in between that time that it takes you to get from 5 to 100.
Right.
And so it's going to be that, figuring out what delivery form is going to work best for you and your body. Some skin is really thick. We can't use transdermal. We can't use the gel or the patch. We have to use injection with some women. Some women, they can't tolerate the oral progesterone. It causes water retention. It causes breast tenderness. It can cause breakthrough bleeding. And then the answer isn't to just load them up higher and higher and higher. I mean, I've heard of some women being told to take like 600 milligrams of oral progesterone. And
Well,
I was like,
Carol
oh my,
Peterson will say that.
yes. And
Yeah.
Carol's very smart. She has done her research. I actually like listening to her talk. I heard her on your podcast. I've heard her on many of my friends' podcasts. And I haven't had her on because I don't want to butt heads with her. But my thought on that process, there's a couple practitioners out there saying that we need more and more progesterone. And to be going upwards of like 1,000, she even sometimes uses 1,000 milligrams of progesterone.
Oh, higher than that. Yeah. Yeah.
And so my question is why is it that progesterone is any different from any of our other hormones like testosterone and estrogen, especially things like and thyroid, where you use too much for the body? Guess what happens? Those receptors get saturated and that no longer works. And so my theory is she gets higher and higher and higher on these progesterone, thinking that that's what's needed. And then suddenly that person maybe starts to feel a little bit better. I think it's just because the progesterone actually stops working because those receptors are saturated. There's no way that that's not happening at that dose. Your receptors would just be like done.
Yeah.
That's too much. And if you're using it all the time and that's not how progesterone should be used, evermore that it's going to be saturating those receptors, and then now your progesterone isn't working properly with your estrogen. We need them to help each other. Estrogen's supposed to come up, which upregulates progesterone receptors, so that when progesterone comes on board, the receptors are there waiting for it and can be used properly. And then the progesterone helps to upregulate estrogen receptors. So if we're using progesterone all the time in these really high doses, you're messing with Mother Nature way too much. And then adverse things start to happen. And so you have to be careful. And then there's progesterone sensitivity, which they're not recognizing. And I think that that's really unfair. They're saying that it's not enough progesterone. I disagree. I mean, I have progesterone sensitivity. If I take too much oral, I'm a mess. I get super depressed. I can't stop crying. And you talk to women like this, and it's like, okay, if you go a little bit higher and it gets better, great. But if not, don't keep going higher and higher and higher. Like that's not like a woman could honestly get to a really dark place by doing that. That was the darkest, I think, and the lowest I've ever felt in my life was when I took too much oral progesterone. I couldn't stop
Oh.
crying for days.
Oh, that's interesting. Okay.
Yeah,
What
yeah.
dose were you on? Just out of curiosity. How much is too much for you?
At the time, it was only 100 milligrams of oral progesterone.
Oh my gosh. Okay.
Yeah. And even now, if I take it too many nights in a row, oral progesterone, I start to feel it. And so I
Oh,
have to rotate it in and out with my cream, and I have to take breaks from it every couple of days. So I usually I don't hardly ever use oral progesterone because
okay.
it can help me sleep. So I'll use it once in a while if I'm having trouble sleeping, but then I know after like 3 nights, I have to stop or else I'm going to get depressed.
Okay, so you are one of those that are a little bit more sensitive to it that
Yeah.
and
Yeah.
and then some women get anxiety from the oral as
Yes.
well. Like if they're not going to tolerate
Yes.
the oral, they'll get anxious instead of chill.
Oh, so bad.
Yeah.
Angry. I've heard some women like they rage. They have rage from it and they lose it. My sister's like that. She takes it too much and she starts to go off the handle. I've had many patients who have said the same thing where it's like, I feel like I'm gonna like rip somebody's face off because I just am so angry. And then other women, it's nonstop crying, depression, can't get up in the morning. They're super foggy brain from it. This is from the metabolites that oral progesterone produces. And they think too, it's one of the number one causes of PMDD, premenstrual dysphoric disorder. is that it's a GABA steroid sensitive neurosteroid sensitivity, it's called. And there's a one woman who has been researching this for a while, and she's on the PMDD sites, and she's great. It's great because I think that she's completely onto something. And once again, it just is like, naturally we're not supposed to be putting the progesterone through the liver and the digestive system, but you can almost look at it as two different drugs, Amie. It's like one of them, the oral, you're going to get sleep out of it for a lot of people, and anti-anxiety, and that's like one drug. And then
Mm-hmm.
the other one's progesterone. And so for some women, having that together is like magic. And like they're like, oh, don't ever take my oral progesterone away from me. They
Yeah.
have to take it every night or else they don't sleep. And it's like, great, go for it. If that's what's working for you, then that's what you should do.
Well, I actually see it in my sleep scores too. When I'm on those 2 weeks of oral, I get deep sleep, restorative sleep. Like my sleep scores are amazing. And then the 2 weeks without, I'm like, crap. It's like half deep sleep. And so yeah, I mean, I can
Yeah.
attest to the help, but I can see the benefit of pairing it up with the
Yes.
cream and the oral.
Yeah. Now I'm going to promote my own thing right now because I just came out with a progesterone melatonin
Oh,
oil.
oh,
And so
yeah.
this is it's suspended in MCT with vitamin E in it. Legally, you can't sell oral progesterone online without a prescription. Okay.
Mm-hmm. Right.
So it'll say on my website, like it's transdermal, but safe for oral intake because it's suspended in that, right? So
Right.
it being in dropper form, you can get very, very, very precise with your dosing. And so if you're somebody that is like, oh, I just want a little bit of progesterone to help me sleep on the nights that I don't have my progesterone days,
Yeah.
you could use a small dose under your tongue and just let it sit there and then swallow it. And that combo of the progesterone melatonin, even at a smaller dose, should still help you to sleep a little bit better. Also, the melatonin combined with it, even if it's just used transdermally, the melatonin, because it's transdermal, we're not losing a bunch in the digestive and the first hepatic path of the liver. And then it's slowly released out through the body. And there's been some good research done on this, on people like nurses and people that do night shifts, and
Mhm.
how transdermal is better because they get this slow release of the melatonin, which then helps them to stay asleep longer. And I actually just had somebody write to me yesterday and say, I took your progesterone melatonin oil and I was able to sleep through the night for the first time. And I don't know how long.
Oh, that's awesome. Oh my God,
Yeah.
that's
So
amazing.
try that. And I'm just going to send you some, of course, Amie, to try, but you can use it both. You can use topical and yeah, which is great. And one
Yeah.
little bottle it can last somebody, if they're cycling it, it could last like a year.
Oh my God.
Yeah, yeah. So it's like super cost effective. It really absorbs nicely into the skin. You can put it, if you have thick skin, you can rub it on the labia. You can put it, like I said, under your tongue and let it sit there for 30, 60 seconds and then
Mhm.
swallow it. Um, and then you're going to absorb it right through the mouth or through the mucosal lining. So, yeah, so give it a try. And you guys you get a 10% discount with Amie. So on
Yep.
your cart,
We'll
which
put that in
is,
the show notes. We're gonna put the
yeah,
link
yeah.
to your store and that discount code in the show notes for all the creams. But we were talking about progesterone cream for the breasts, and then now the progesterone oil. What would be fun is if we gathered like 20 insomniacs because we all know them amongst our
Yep. Yeah.
ladies. And if we stack that with my new sleep fixer too, I bet we could get people
Ooh.
sleeping. And then there's a sleep stack for us on both. There you go. And now we'll pair up your progesterone. Oh, you froze for a minute. Wait, let me give it a second.
Oh, there we
There
go.
you
We're
are. Okay,
back.
you're back. So
Did you hear me? I said, what's in the new sleep fixer?
So a sleep fixer has a Kirk parsley dose of melatonin. So even if we paired it
Perfect.
with your melatonin, it's not gonna be this super high dose where people are getting nightmares and all that
No,
crap.
yeah, yeah, yeah.
Inositol, GABA, magnesium, a little bit of valerian, a little bit of passion flower. So it's
Perfect.
basically, I took what worked for me to finally get me off of sleep medication and
Yeah.
put it all together outside of the Delta 8. You know, I do like
Yeah.
I
Yeah.
like my
Yeah.
Delta 8 too, but we
I
can't
know
sell
you
that.
do.
So
Yeah.
we can't sell.
Not
So
yet.
yeah, we have a sleep stack, and then if we combine the progesterone cream and iodine fixer when that comes out, now we have a breast pain stack.
Yes.
Bam.
I love it. I love it because that's our goal, you and I, is to have solutions to all of these for women because there's really not a lot. And I think a lot of what's on the market, I'm not dissing anybody's, like there's some great products for women on the market, but majority is just like this mix mash of stuff that they really don't have a clue. Like things that like everything contains dim in it for hormones. And
Oh,
it's like, well, menopausal women should not be on dim because it lowers, unless they're having like real problems with that 4-hydroxylation pathway, like
right.
maybe then you take some. But in general, that's going to tank your estrogen levels, which you're trying to keep up in menopause, not to tank.
Yeah.
And so you have to be very careful with what you're using. That same with adrenal supplements. Like it's just what you're
That could be a
finding
whole
out
other
there.
podcast.
Oh,
Yeah.
I know. It's just be careful, people. Be careful of what you're buying. And yeah,
Yeah.
as always, work with somebody if you're having troubles.
Yeah. Yeah. Exactly. That's the bottom line. Yeah. Work
Yeah.
with us, buy our stuff because we got your back.
That's all.
That's
Just work
just a
with us by
shameless
ourselves,
plug, but we can say that on here. Yeah. Yeah. Well, no, it's true though. I mean, and just for the listeners' knowledge, before I let you go,
Mm,
I see what Karen goes through to put quality and love into her products. Like I know the
mhm.
behind the scenes. And I can tell y'all, I mean, we before we put something on the market, we get samples, we test it, we test levels, we try it on other people. Like we make sure that it works before we put our name on it and put it out there. So when
Yeah.
you're talking about the world of hormone solutions, Karen's got your back on it. It's the highest quality of anything hormone based that I have ever seen on the market.
Well, and then right back at you because your formulations are you're very particular about what you're putting in your products. And I was just talking to the woman that owns Vitali. I just did an interview with her, and I was talking to her about this, which is women like us that are in this industry, in the supplement industry or in the health industry, we really do stand apart from the big names, right? And because of that, we have love and attention to everything that we put out there
Yeah.
because we care about women. We're working on the front lines with women. We're not
Yeah.
some great big company that's just like, let's market the crap out of menopause and just shove these supplements in their face and try and get them to take everything that we're putting out there, no matter what it is. That's not our intention. Our intention is what can we have? What can we give to these women that's actually going to help? And we
Yep.
put that care and love into it, which I think is really important. And that makes us stand out from other people.
Yep. Absolutely. Well said. Well, thank you so much for jumping on today and breaking down these topics. I absolutely love it. I think it's such valuable information for women
Yeah.
out there. And tell people where they can find you, and we'll put the link to the creams and your whole store in the show notes.
So KarenMartell.com. The podcast is Hormone Solutions, and Amy's going to come back on soon for her fifth interview on my show, I
Something. Yeah,
think,
I don't know what we're
Amy.
up to now. Yeah.
Which is great. I can't wait. But yeah, so that's usually the best way to find me is my podcast or to get information. And there's so much about hormones on there, and I give it all away. So
Yep, I
like,
know. That's what we do. We just give it away. And then when people
yeah,
need us, we're here for
yeah,
you. So,
exactly. Yeah,
all right, my
yeah.
dear.
We give
Thank you,
back.
Karen, so much for jumping on. And we'll put all of her links in the show notes as well.
Thanks, Amy.